Welcome, Professor Butler here. We're going to talk a little bit about the endocrine system, okay? Just a little bit of review, all right? So we are going to start with the hypothalamus. Okay, so we're going to start off with the hypothalamus, all right? So the hypothalamus is going to either release hormones to get more production or inhibit. You do not need to know any of the hormones that are released by the hypothalamus, but you do need to know that the gland that the hypothalamus, the hormones the hypothalamus releases, acts on one other gland, and that gland is the anterior pituitary. Okay? So we have our anterior pituitary gland, okay? And the anterior pituitary gland releases 7 different hormones, okay? Those hormones are ACTH, adrenocorticotropic hormone, okay? So that will work on the adrenal glands, okay? So that's the first hormone. The second one is growth hormone, which that acts on the tissues and on the bones. Then we've got TSH, thyroid stimulating hormone, which is going to act on the thyroid gland itself, okay? Then we've also got luteinizing hormone, follicle stimulating hormone, prolactin, and melanocyte stimulating hormone as well, okay? For our purposes, these two have to do with reproduction. This has to do with breast milk production. This has to do with pigmentation. For our purposes, we are going to focus on ACTH, growth hormone, and thyroid stimulating hormone, okay? So we're going to start with that premise, right? So we are going to start with ACTH, right? ACTH works on the adrenal glands, okay? We've got our adrenals. The adrenal glands are comprised of 2 different sections, the adrenal cortex and the adrenal medulla. Okay? So in our cortex, and again, ad means on top, renal means kidneys. So the adrenal glands are located on the top of our kidneys. And we've got our medulla. Okay, so cortex and the medulla, all right? When it comes to the cortex releases 2 different substances. One is glucocorticoids. Okay, our primary glucocorticoid is cortisol, our stress hormone. Okay? The second thing that the cortex produces is our mineral corticoids. Our primary mineral corticoid is aldosterone. Okay. Okay. So we're going to start there. Okay. So the medulla, which we are not focusing on, but this is where it produces what are called our catecholamines. Catecholamines that's our fight or flight. Okay, so when your body goes into and releases epinephrine or norepinephrine, that is coming from the adrenal glands, the medulla portion of it. Okay, but we're going to focus on our cortex. Now, while we don't specifically cover hyper and hyperfunction of the cortex, known as hypercortisolism or hypocortisolism, you do need to understand it because the anterior pituitary, we are covering the hyper and hypopituitary isms. Okay, so starting with that premise. Okay, so we have both hyper and hypo. Okay. All right. So as we are looking at these, and what you're going to do, guys, is as you're looking at this, look at your prefixes, right? When we are looking at hyperpituitaryism, so something that is not a primary, so if the disorder is in the gland itself, it is known as a primary disorder, Okay? If the disorder is because of one step up in the cascade, anterior pituitary is considered a secondary disorder. If it is farther up on the cascade at the very beginning, it is known as a tertiary disorder. Okay? So we won't have any questions specifically about primary adrenal disorders, but you may have questions on secondary adrenal disorders as either hyper or hypopituitarism. And what you're going to look at, guys, is when you're thinking hyperpituitarism, you are thinking hypercortisolism. So match your prefixes, hyper and hyper. Okay? If we have hypopituitarism, you are going to think of hypocortisolism, right? So that's where we're going to start off with that. Okay? So when we are thinking hypofunction, okay? So we are thinking hypofunction. So in this case, hypofunction of the adrenal cortex or hypopituitarism. When you're thinking hypofunction, you're thinking a couple different things. Okay? So the first thing, sorry, lost the light. Okay? So when you are thinking hypofunction, all right? Actually, I'm going to bring it over here. Make this work better. Okay? So when you are thinking hypofunction for the anterior pituitary, so we are thinking hypopituitarism. Okay? We're thinking a couple different things, right? So hypofunction for hypopituitarism or hypocortisolism, we're going to have hypofunction. So for hypofunction, cortisol should be decreased. Okay? And as we know here, that glucose portion is glucose. So guess what else is going to be decreased? Glucose. Glucose is also going to be decreased. Okay? But then we also have to look at our mineralocorticoids, because what does aldosterone do? Okay? So aldosterone has to do with our ability to promote sodium reabsorption and potassium excretion by the kidneys. Okay? So when it comes to hypofunction, so if our mineralocorticoids aren't working very well, then we're not going to get that sodium reabsorption. So if we don't get sodium reabsorption, our sodium levels are going to decrease. Right? And as we know, what follows sodium? Water. So if sodium's decreased, what's going to happen to our blood pressure? It's going to also be decreased. Right? So not only does those mineralocorticoids to our aldosterone, not only does it affect the ability to reabsorb sodium, it also helps us excrete potassium out of the kidneys. All right? So if we have a low amount of that, guess what? The kidneys aren't going to be excreting as much potassium. Guess what happens? Potassium goes up. Okay? So as you're looking at hyper and hypocortisolism having to do with the cortex, either insufficiency or having a hyperfunction, in that case, you're matching those up. So hypercortisolism would correlate to hyperpituitarism. We just went over hypofunction. So hypocortisolism or hypofunction of the adrenal cortex could be linked to hypopituitarism. Right? So now let's do the opposite. So if we know what hypofunction of this cortex means, let's talk about what hyperfunction means. Okay? And when you're looking at the hypers and the hypos, they're just the opposite. Okay? So there's your hyperfunction. So in this case, it should not surprise you that our glucose should be increased, as we have a hyperfunction. Guess what else is increased? Our cortisol levels. Okay? And again, we also have to look at our mineralocorticoids, which our primary one is aldosterone. So in that case, guess what? That reabsorption of sodium is now going to be hyper. So our sodium will be increased. Again, we know that water follows sodium. So what's going to happen? Blood pressure is going to go up. Okay? So BP is increased. And again, the mineralocorticoids is also used to excrete potassium out of the kidneys. It's that hyperfunction. Guess what's going to happen? It's going to excrete a lot of it. So we are going to have low potassium. Okay? So as you are looking at your pituitary isms, when you are looking at hypopituitarism, you're going to look at hyperfunction of that adrenal cortex. When you're looking at hyperpituitarism, you're going to look at that hyperfunction of those adrenal cortex in both the cortisol and glucocorticoids here, as well as our mineralocorticoids here. All right, so far so good. Okay, then we get into our growth hormone. Okay, so growth hormone. Both ACTH and TSH are considered tropic hormones. What that means is it's a hormone that acts on another gland, right? That anterior pituitary releases ACTH, which acts on the adrenals. For thyroid stimulating hormone, okay, we have got TSH that is going to, again, a tropic hormone, which is going to act on the thyroid gland itself. Okay, all right. But when it comes to growth hormone, it is called a somatotropin. Those are interchangeable terms. Make sure that you are familiar with that. Somatotropin. So what is affected by growth hormone? Both our bones and tissue. Okay. So for each of these disorders, again, you've got hyper and hypo for our adrenals. We're going to have both hypo and hyper for our growth hormone. Okay. And hypo. Okay. So again, if a patient's got some type of anterior pituitary problem, so let's start with hyper. So if a patient has hyperpituitarism, they're going to have excessive amounts of growth hormone that are going to affect the bones and the tissue. Okay? When that happens, so we're going to have hyperfunction. And as we know, what ends up happening is a lot of times the bones are what tend to keep growing. So your patient is going to have large, coarse facial features, an increase of the mandible, increase of the hands, and increase of the feet. Okay, so that's going to be the hyperfunction of growth hormone. Okay, we affectionately call that acromegaly. Acro meaning extremities, megaly meaning enlargement. Okay. Then we've got hypofunction, okay? So if a patient were to present with hypopituitarism, they're not going to have enough growth hormone. That is going to affect their bones specifically in adults. When you get to pediatrics, it plays a slightly different role, but we're talking about adults here. So our big concern with a patient that has hypopituitarism, they will present with that hypo for growth hormone, that underproduction. And that underproduction leads to a decrease in bone density. So a patient that has hypopituitarism, an adult patient that has hypopituitarism, our big concern is that bone density, bone fractures, right? So we need to be concerned about things like falls, right? How we move the patient, using bed sheets to ensure that we aren't part of the problem, but also keeping the patient safe, okay? Then our last one is our thyroid stimulating hormone, okay? So the thyroid releases 3 different types of hormones. T3, T4, okay? And make sure that you know the names of these disorders, or excuse me, of these hormones, okay? Triiodothyronine and thyroxine. Make sure that you can recognize that, not just T3 and T4, because on any ATI, NCLEX, you may see either or, okay? These have to do with the thyroid, and the thyroid is concerned about metabolism, so that's where our thought process goes. The third hormone that the thyroid releases is thyroid calcitonin. And thyroid calcitonin comes in when we start talking about parathyroid, because it juxtaposes the parathyroid, they're each other's yin and yang. When our calcium levels in our blood drop, the parathyroid kicks in and says, hey, all right, we need to get more calcium into the bloodstream, works on the bones, the GI tract, and the intestines to absorb or release more calcium from the bones or absorb more in the intestines and in the kidneys, right? On the flip side, when our calcium levels are too high, the thyroid gland releases thyroid calcitonin that says, hey, deposit more in the bones, stop uptaking as much calcium in both the kidneys and the intestines, hopefully decreasing. So this one is the yin and yang to our parathyroid, okay? So let's go back to our thyroid gland, okay? So then we've got our thyroid gland, and we've got our hyper and our hypo, okay? And as you think about it, think about metabolism, right? That fast metabolism. These patients present with weight gain, even though they may eat more, okay? Insomnia, they're going 100 miles an hour, they're always hot, they don't tolerate heat. Then on the opposite, hypo, think low and slow. Okay, so again, that weight gain, these patients present a lot of times with constipation. These patients a lot of times have active bowels, sometimes even to the extent of having diarrhea. But keep in mind that with the thyroid, a patient can have either a primary thyroid disorder, which you will have questions regarding primary thyroid disorder, so make sure that you know the difference between hyper and hypo, right? But they can also have secondary. So both hyper and hyperpituitarism can lead to hyper or hypothyroidism. All right? And once you learn these, this is mainly covering all of your hyper and hypopituitarisms. Remember, focus on ACTH. So you do have to understand the adrenals, okay? Understand growth hormone, that one just is on bones and tissues because it is not a tropic hormone. Then you've also got thyroid stimulating hormone that acts on the thyroid gland that can lead to both hyper or hypothyroidism. Hopefully this should help you. Let me step to the side to make sure that you can see all this. But hopefully this should help you in your studies for the endocrine content.